Okay, we're going to go ahead and get started with the next session. As part of the Outcomes and Evidence-Based Practice Committee, today we're going to be presenting our systematic review of the treatment of lymphatic malformations in children. My name is Teddy Huerta. I'm a resident from the University of Miami, along with my colleagues on the lymphatic malformations subgroup. So, lymphatic malformations, as a form of slow-flow congenital vascular anomalies, occur with an incidence ranging from 1 in 2,000 to 16,000 live births annually in the United States. And while these lesions may occur in any anatomic region, they tend to predominate in areas rich in lymphatic channels, with the majority occurring in the head and neck, as in this patient here. Since 1990, the International Society for the Study of Vascular Anomalies instituted a classification system for lymphatic malformations, dividing common cystic lesions into 3 major histologic types, including macrocystic, microcystic, and mixed cystic malformations. Ultimately, 3 major modalities of treatment are popularly utilized, either in isolation or combination for pediatric patients with lymphatic malformations, including systemic therapy with mTOR inhibitors, percutaneous sclerotherapy, and surgical excision. It should also be noted that observation is a viable management strategy for many malformations. However, we did not explicitly review literature related to this strategy in our review today. As part of the Outcomes and Evidence-Based Practice Committee, the Lymphatic Malformations subgroup created and refined the following 3 research questions related to the indications, efficacy, and complication profiles associated with medical therapy, percutaneous sclerotherapy, and surgical resection. With the aid of a health services librarian, we initially identified 9,326 abstracts that each underwent independent review by 2 members of our lymphatic malformations subgroup, and after application of our exclusion criteria, resulted in 202 full-text manuscripts that were abstracted for data presented in the following qualitative analysis today. So if you'd like to pull out the Whova app and begin, we'd like to first start by polling the audience with regards to the following clinical scenario. A 3-year-old boy presents with a mixed but mostly macrocystic abdominal lymphatic malformation encompassing almost the entire abdomen. In your practice, do you most frequently offer systemic medical therapy, sclerotherapy, surgical resection, a combination of sclerotherapy and medical therapy, or referral to a vascular anomaly center? And while you continue your answer, I'd like to introduce the next speaker from our subgroup, Dr. Brian Englam from the University of Maryland Children's Center.
All right, so looking at the polling results here, it looks like a little more than a third would offer sclerotherapy and medical therapy. Another 25% would offer sclerotherapy. A few would offer surgical resection or referral to a vascular anomaly center. And no one has offered systemic medical therapy alone, which is a perfect segue into question 1. So looking now at systemic medical therapy, we found 28 studies, including 343 patients, which met our study inclusion criteria. The majority of these were retrospective, although almost 40% were actually prospective studies. Level of evidence was uniformly 4, except for 1 RCT that was included, and the minors criteria ranged from 8 to 19, indicating mostly low quality studies. The majority of patients in these studies had head and neck lymphatic malformations. Most patients had extensive disease or disease that had failed previous treatments, including surgery and sclerotherapy. We found no studies that compared systemic medical therapy to another therapy, and our 1 RCT actually compared sirolimus, the timing of administration of sirolimus, not comparing sirolimus to another therapy. We can see here the efficacy of several medications that had enough data for summary statistics. So sirolimus clearly had the most robust data, but sildenafil and TJ28 also had data. Sirolimus is an mTOR inhibitor, and its mechanism of action involves decreasing activation of T lymphocytes and lymphangiogenesis. TJ28 is a herbal medication that is purified and approved in Japan and has several studies related to it. The mechanism of action is also thought to be on the mTOR pathway. So focusing on sirolimus, the radiologic percent of patients having some radiologic improvement was nearly 90%, similar to the TJ28 data, but the radiologic reduction was relatively modest, about 50% decrease in the lesion size. With the exception of sildenafil, these medications had almost uniform 100% clinical response for patients, which included improving symptoms, decreased pain, and improved functional status of the affected area. And as you can see here, very few patients, only 3.4% in the sirolimus group, had a complete response to systemic medical therapy. Looking now at complications, you can see again the most robust data for sirolimus. TJ28 actually had no reported complications in the studies that we looked at. In sirolimus, dyslipidemia was present in 20% of patients, and 28% had mucositis, 11.5% had elevated LFTs, and in about 10% of both the sirolimus and the sildenafil groups, there was a report of either late growth or a late recurrence. So in conclusion, for our systemic medical therapy, medical management can achieve partial response for extensive lymphatic malformations that are refractory to surgery or sclerotherapy. The most robust data is available for sirolimus, but TJ28 may be an interesting area for future research. Most patients experience a moderate size reduction in their lymphatic malformations, but almost all experience some symptomatic improvement. Macrocystic lesions respond better than other subtypes, and although complete response is rare, these medications are generally safe with low-grade complications, if any. These are grade C recommendations based on level of evidence 4. And with that, I will turn it over to Dr. Rylon for a discussion of percutaneous therapy.
Okay. So for sclerotherapy, we included 123 studies with 3,600 patients. Most of these were retrospective, although 15% were prospective observational studies, with the level of evidence varying from 2 to 4, and most of these were poor quality evidence studies. So it's important when you think about sclerotherapy for these to look at the type of malformation. And in our cohort, there were 52% were macrocystic, which is generally defined as when the cyst is larger than a centimeter, and 19% were microcystic, and the rest were mixed. Looking at the efficacy of sclerotherapy, there was a 51% complete or near complete response rate, which was generally defined as a radiologic response over 90%. 44.2% had a partial response. Recurrence is a difficult term to define, I think, for sclerotherapy because often these patients require multiple episodes to achieve that complete or partial response. But overall, the recurrence rate was 7.3%. We did a meta-analysis, and it was very similar to the above table with a 51.5% complete response, and 97.4% of patients had any response. Looking at efficacy by the type of lesion, there were 20 publications that demonstrated that macrocystic lesions had a superior response to sclerotherapy compared to mixed or microcystic lesions. There were 5 publications with 119 patients that looked at microcystic lesions alone, and these used bleomycin and 2 other agents that we don't really use in the US as their sclerosing agent. There's actually a pretty good response rate, 49% complete response and 49% partial response. Looking at complications, 13 papers did not report on complications at all. 11 papers showed a 0% complication rate. And by far the most common complication that was reported was this periprocedural inflammatory response in 53.7% of patients, which is fever and erythema that generally resolves in 24 to 40 hours without any intervention. These are the 3 most common sclerotherapy agents that we reviewed in our manuscripts: bleomycin, doxycycline, OK432. And I should mention that OK432 is not FDA approved in the US, so all these studies are from Asia. By far the most common complications seen are infection, bleeding, and skin pigmentation. Area obstruction was up to 17% in OK432. And I also should note, when you're comparing sclerotherapy and surgery, that the nerve injury rate is low with sclerotherapy. There were other agents that were used, but these are really not often used I think at the larger vascular anomaly centers, and there's overall a very low complication rate. So to conclude, sclerotherapy is effective for over 90% of patients. Macrocystic lesions have a higher response rate and are more likely to show a complete response, but sclerotherapy, particularly with bleomycin, is effective for achieving at least a partial response rate for microcystic lesions. Periprocedural inflammatory reactions are common, and patients should be counseled about this, and often there's no intervention that needs to be done. Bleeding, infection, skin pigmentation, and area compromise are the most commonly reported complications. This is a grade C recommendation with level evidence 4. So we're going to open up with our next polling question. So you have a newborn with a large cervical facial lymphatic malformation, but there's no airway compromise. The lesion has large macrocysts and some smaller areas with microcystic component. In your practice, do you most frequently offer systemic medical therapy followed by sclerotherapy when older, systemic therapy and sclerotherapy as a newborn, surgical resection as a newborn, no intervention until older, or referral to vascular anomaly center? And I'm going to turn it over to Dr. Levine.
Okay, so last but not least, we're going to talk about surgical resection and the indications in lymphatic malformations. There were 115 studies that met inclusion criteria, which accounted for about 3,000 patients. I should note that most of these were retrospective, although there were 2 prospective observational studies that were included. So we broke down the surgical resections based on anatomic location. First, we looked at cervical facial lymphatic malformations, that being the most common subtype of lymphatic malformations or location. There were 51 studies that met inclusion criteria for surgical resection. And you can see that the majority of these were characterized as being of the head and neck location without further specification. There were some studies, though, however, that did break it down further as far as where within the head and the neck the malformations were located. The morphology was reported in a little bit over half of these papers, and I should note that there was some variation as far as the definition of macrocystic versus microcystic lesions, with some papers reporting 1 centimeter as a cutoff, some papers reporting 2 centimeters as the cutoff, and some papers just not specifying what they consider to be macrocystic versus microcystic, making comparison obviously difficult. So about half of all the patients who underwent surgery for lymphatic malformations did have lesions that were in the cervical facial region. The studies that we included reported anywhere from 3 to 128 patients, and I should note that a subset of these patients also did undergo some form of adjuvant therapy. Someone's phone is up here. Anyway. As you can see listed, and that the adjuvant therapy was not always separated out in the analysis, which also limits our ability to be able to compare outcomes for these patients. A little over half of our studies did describe an attempt at complete excision. This was done in about 75% of the cases, but ranged from anywhere from 11 to 100% of the time in the studies that were included. And of the patients who underwent an incomplete or a partial resection, the extent of surgery was not always described, again, making comparison between the outcomes and results somewhat difficult. So of particular interest in patients with cervical facial lymphatic malformations, as far as indications for surgery unique to this population, are concerns with dysphagia, or swallowing or eating difficulties, as well as airway obstruction and respiratory compromise. Additionally, there were a fair number of patients who had undergone prior attempts at various therapies, including sclerotherapy, prior to an attempted surgery, and this also impacts recurrence rates and outcomes just because of scarring and other associated complications with other therapies. So looking at outcomes, the overall complication rate for patients with cervical facial lymphatic malformations that underwent cervical resection ranged anywhere from 0 to 88% in the 36 studies when this was reported. These included intraoperative complications, perioperative complications, as well as long-term postoperative complications. And as mentioned earlier, one of the greatest types of complications that's seen is that of nerve damage. I should note that the majority of the nerve damage that was reported tended to be transient, typically resolved within 2 to 6 months of the time of surgery. However, there were some patients for which the nerve damage was permanent. There were 213 cases of recurrent disease that were reported. This accounted for about 15% of all of the surgical cases of lymphatic malformations in the cervical-facial region and ranged anywhere from 0 to 56% in the studies that it was reported in. About half of these patients subsequently underwent re-excision or reoperation for recurrent disease. And of course, we have to consider other factors that might impact recurrence, such as those that are listed in the slide above. Now, shifting gears to abdominal and retroperitoneal lymphatic malformations, there were 31 papers that were included. These were all retrospective, and only 2 of these included the subtype of malformation, whether it was macrocystic or microcystic. There were various indications for resection, and the most common indication was that of abdominal pain. There were 358 patients that were included, and the papers reported anywhere from 3 to 47 patients. The outcomes that were examined were heterogeneous, thereby also making comparisons somewhat challenging. The majority of these patients did undergo a single-stage resection or complete resection with very low recurrence rate when this was successful, anywhere from 0 to 14%, but again, it was not a uniform outcome that was reported in all of the papers that we looked at. The most common complication reported was that of bowel obstruction, which makes sense because when resecting an abdominal or retroperitoneal lymphatic malformation, oftentimes this does involve a bowel resection, given the mesenteric location of the lymphatic malformation. All in all, what we found from the papers that we evaluated was that surgical resection of abdominal or retroperitoneal lymphatic malformations can often result in complete resection with low complications and low recurrence rates. These papers, however, were all retrospective, of somewhat poor quality with heterogeneous outcomes, and an overall small number of patients that were included. And so finally, the last group that we looked at was that of lymphatic malformations that were not in the anatomic locations I've already reported. So we called these mixed locations. There were 29 papers that were included, with about 1,200 patients included. These studies also were all retrospective, and the number of patients that were reported upon were anywhere from 4 to 185 in each of the papers. Only 5 of these papers indicated the morphology, and the most common indication for surgery among these papers was that of an increasing mass size. And again, the outcomes that were evaluated were heterogeneous, making comparisons somewhat difficult. The majority of these patients did undergo a single-stage resection or complete resection, or at least an attempt at a complete resection, with recurrence rates ranging anywhere from 10 to 100%, but again, this was not uniformly reported. The most common complications seen following surgical resection of these lymphatic malformations in mixed locations were chyle or lymphatic leak or infections. Overall, however, the complication rates were relatively low, and it was seen that surgical resection can often result in complete resection with low recurrence and low complication rates. These papers, however, also were of retrospective nature, were poor quality with heterogeneous outcomes, and again, just a small number of patients typically reported. So in conclusion, the surgical management is a useful strategy. There's a time and place for it, and it should be considered as part of a larger multidisciplinary approach, which needs to be tailored to each individual patient and each individual case. We know that the data that was evaluated was heterogeneous with regards to the anatomic location, the subtype of lymphatic malformation, the outcomes that were reported, as well as the extent of surgery. And that when complete or single-stage resection is achievable, that generally there are low recurrence rates and relatively low complication rates. This, however, does depend on the location, the size, and the subtype, as well as the extent of resection. So we also gave these grade C recommendations with level of evidence 4. And with that, I'll turn it to Dr. Barras to wrap it up for us.
All right, I'm sure by now everybody is crystal clear on how to manage all of these patients with their various malformations. So in conclusion, to summarize our systematic review, medical management can achieve partial resolution of extensive lymphatic malformations or those that are refractory to surgery or sclerotherapy and can be used as adjunct therapy. Sclerotherapy can achieve greater than 90% partial or complete response in various lymphatic malformations and is most effective for macrocystic subtypes. Surgery can be considered depending on the size and location of the lesion. All of these recommendations are grade C and level of evidence 4. Optimal management should focus on a multidisciplinary approach to individualized therapy for each patient. And I'm just going to run through our polling questions. So the first question about the 3-year-old boy with a mixed abdominal lymphatic malformation encompassing almost the entire abdomen. Just like our evidence showed, there's really no one clear answer, and the answers were actually quite split between sclerotherapy, surgical resection, surgical and medical therapy, and referral to a vascular anomalies center. The newborn with the large cervicofacial lymphatic malformation, the answers were really split between systemic medical therapy followed by sclerotherapy when older, medical therapy and sclerotherapy as a newborn, no intervention at all until older, or referral to a vascular anomalies center. And then the last question regarding care of patients with lymphatic malformations. Most people manage the patients with their colleagues and other specialties on an ad hoc basis, or have referred to a vascular anomalies center. So it sounds like everybody is practicing based on what the evidence shows and managing these patients on an individual basis. I'll now be happy to turn it over to Doug Miniati from the Quality and Safety Committee.
So you just hit the read button when you want to go?
Yeah, it doesn't seem to be going.
Thanks, Alana, and thanks everyone for your endurance in getting to these end of day sessions. It's been a great day so far. And I just want to make a note that especially the folks who are standing at the back, the bar will not be serving beer or wine unless you've been a seated attendant at this session. Just want to also thank my partner in the development of our quality and safety toolkit for lymphatic malformations, Jason Slakowski from Richmond. And we've already kind of covered this question. And I like to tell my patients that these are like snowflakes. They're all different. They require very individualized care, but it's still very helpful to see what the preponderance of evidence shows thus far. So before I jump in here, I just want to, just by show of hands, how many people here have used a APSA QSC toolkit in the carrying out of a performance improvement project in their hospital? There's a handful. Okay. How many have visited the Quality and Safety Toolkit website? And how many before now have heard of the Quality and Safety Toolkit? Okay, that's great. The team puts a lot of work into these. The last session, if you missed it, was really great, and one of the sort of aha moments for me from it was the presentation about implementation science, and it's sort of like the next level of once we have all this evidence and data and protocols, the soft science of how to implement these toolkits, and I think that really is the next phase and the challenge for us in using these. And a lot of work goes into putting the toolkits together, and we hope that through the promotion of these toolkits and the use of them, that our care for surgical patients will overall improve. So how do you get to the toolkit? There are a few ways to get there. The one easy way is through the APSA website. You simply don't even have to log in. Just hover your mouse over resources and then pan down to resources and over and click on the Quality and Safety Toolkit. You could also just Google search APSA Toolkit. You don't even have to put QSC in there. Just APSA Toolkit gets you there. Or you can go to this website that I have in the link up there. And at the end of this, I'll flash up QR codes for us. Once you get to that main page of the Quality and Safety Toolkit that you can see here, just click on Lymphatic Malformations, and then click on the blue box, Lymphatic Malformations. And that'll take you into the folder. And all the Quality and Safety Toolkits have a read first file. So you want to check that out. That will explain what the contents of the folder are and what the purpose of the toolkit is. So in the read first file for our lymphatic malformations toolkit, this one is a bit different because there as yet have not been any real robust published studies on quality improvement projects in this area. And so we devised, Jason and I, this folder, this toolkit, to be a collection of materials that can help one establish, develop, or streamline their own vascular anomalies program. And so you can see, maybe not see, that this description includes the different folders that you'll find in this toolkit broken down into program development, treatment algorithms, key references, and then a library of epic smart phrases in all different areas that you can just plug and play into your own EHR. And so you, for example, might want to zone in on what some of the treatment options are. So if you open that folder, you'll see that we've subdivided the treatment into different vascular anomaly types. And if you are interested in lymphatic malformations, because you've learned everything today, you can zone in further, and you might be interested in looking at the general algorithm that's used by CHLA, or if you want to get more specific, we have a very specific protocol from Kaiser Roseville. This is an example of what that general treatment algorithm from CHLA looks like, and this is the specific treatment algorithm that we use at Kaiser Roseville, including who does what when, down to what the concentration of doxycycline is used. And you can just copy and paste this text into a nursing communication order or a progress note, and that way the whole team is aware of what's going on. So that's just one example. There's a tremendous amount of information in the toolkit. I encourage you all to go visit it and explore. And as I said, there haven't been any really robust quality improvement projects published in this area. These are some proposed ideas. These are also listed in the toolkit, and we hope to see your participation in the future. Thanks very much.
Like a minute for questions if anyone has any. Otherwise, QR codes. It's a new, like, get everything you need. Thanks so much, you guys.
Ooh,
Really.
there's a question.
Oh, oops, sorry.
Kath.
Roshni.
So thank you guys for doing this. Roshni Escaptor from Cincinnati. So as you guys know, there's a lot of stuff going on in vascular anomalies. And one of the things that I think we all need to be aware of is sirolimus is, when we did this trial in Cincinnati and Boston 15 years ago, it's really, the field's really evolved to PI3 kinase inhibitors and things that are actually happening in vascular anomaly centers that have really changed how we think about vascular anomalies and what the role of surgery is. And I think both Steve and I have seen lots of complications from surgeons that have been doing multiple resections. So Brian, when you kind of talked about like sirolimus as an adjunct, it's actually, or medical therapy is really becoming the primary therapy. And I think as surgeons, we have to really think carefully, are there other options to surgery? Because I think as surgeons, we can really mess things up and cause a lot of long-term complications. There's definitely a role for surgery, but it has to be within a multidisciplinary spectrum.
That's a great segue for Friday. Annie Kolengowski is going to be talking about some of the other medical therapies like Pelisivimab or Vijoice, I think is the brand
Last
name.
question.
I wouldn't have a question. It's Steve Fishman from Boston. I just want to say thank you, and I want to say it warms my heart that APSA would have a session and so many people be in the room and so many people so knowledgeable about lymphatic malformations and vascular anomalies in general, and to see you citing the International Society of Study of Vascular Anomalies on several slides, having our classification up. We've come a long way, and I appreciate it so much. I would make a pitch. So for decades, I was one of the only American pediatric surgeons at that meeting. We had a meeting a few weeks ago, and several people in this room, including one on the podium, was at that meeting. And for those of you who are interested, what you see is lousy evidence, right? We just saw all the evidence in the World Review. It's lousy, low-grade evidence because everything is heterogeneous and requires expertise and experience and teamwork, and the answer to every question was work with your colleagues. So for those of you who do have an interest in developing expertise locally, please join ISFA and please go to the website and participate, because this is the answer for these children, is working together. Thanks for your expertise.
Thanks, Dr. Fishman. Thanks, everyone.